welcome to the Security Nurse Podcast. Today I have with me Andy Prisco. Andy, how are you?
It's great to be here. I'm doing well. Thank you.
I'm so excited to have you on today. We're going to talk about de-escalation, crisis intervention, crisis response, fear care. We got a lot to cover today.
Yeah,
Yeah, but first off, will you tell our audience a little bit about you? And then the other question I like to ask our guests opening up is what was kind of that aha moment that has now led you to what you're doing today?
that's a great question. Well, first, let me just say, Sarah, I've been following your work on the Security Nurse podcast, and it really is a privilege to have been asked to be a guest and talk about the things that I feel very passionate about with your audience. And I just want to thank you again for the chance to be here. You've had some wonderful guests on so far. As you know, some of them are colleagues of mine. I'm thrilled that I'm part of that lineup, as it were. Yeah. So, my story, I would say what allows me to say what makes me a guest on your podcast or anyone else's podcast about this topic is the fact that uh, I'm a person who worked in a psychiatric care and services setting for many years that witnessed an extraordinary number of traumatic and emotionally imprinting events upon people served and members of the workforce. Those events include episodes of acute psychiatric distress, violence between patients, violence between patients and staff, episodes of seclusion that were particularly traumatic for people served in the workforce, episodes of mechanical restraint, transitioning people from seclusion to restraint because they began to engage in self-harm, extraordinary numbers of episodes of people engaging in self-harm, up to and including serious or life-threatening injury. And upon witnessing all of those things, I found a knack at being of some value to a person served when they were in a state of discontrol or dysregulation. And there was one such event at one of the nation's, let's say, largest and most violent systems, in which my response to the event coincided with the presence of the Metro SWAT team, where a patient had attempted to set fire to a unit, then was moved to another unit and was able to secure the magnetic key card off of an employee, move into a secure non-patient care area, barricade himself in a room with bleach and chemical and ammonia and the creation of fire load, taped a knife to a crutch, and was going to start another fire or smoke people out with chlorine gas. And we were able to, essentially, the hostage negotiator on site and I were able to assist that person in surrendering without a use of force. While a use of force was being planned, they had sent FLIR cameras into the room. I was looking at the patient through a monitor, and they were planning on some kind of forcible entry to try to prevent that person from mixing all of these chemicals together and creating an equivalent. That event set the stage for an opportunity for me to create and lead what became known as the Psychiatric Emergency Response Team in the state of Washington. That included the program and its training known as ACIT, which is Advanced Crisis Intervention Training. And that's the training that I continue to make available to the world across a lot of sectors today. But it was that kind of origin story of witnessing a lot of adverse events, going to a significant adverse event, and then getting an opportunity to create a program that empowered workforce members to respond to events in an organized way using only their words to reduce risk, reduce seclusion and restraint, and reduce injury. And that's precisely what happened when we did that. And the training method within that program became visible to a number of sectors: public safety, other parts of the behavioral health system, corrections. And that started a journey that led me to where I am now, where I completed a career in psychiatric care and services in the forensic care system here as the clinical training manager. And then during COVID, the demand for de-escalation training and the particular method that we developed on PERT became so in demand that I left state service to start Jumpstart Mastery. And that's all that we've done for some years now. And the needs in our world for that kind of training are just extraordinary. And I guess I would just finally say, before completing my answer to that thought, is thank God for people like Greg Smith in Pennsylvania, who's like He's a mentor of mine. I call him the Moses of PERT. This is like the guy that came down off the mountain with the tablets of what to do to reduce containment procedures, to do no harm, and to put your best people at the site of people of emergency. He had already led Pennsylvania to a seclusion and restraint free system, which it remains today. And he was super generous in his guidance to me of creating the PERT methodology here in Washington. So we continue to work together and collaborate both domestically here in the United States and abroad. And that's the best way for me to describe the answer the first part of the question. What was the second part of the question? It was
I think you answered it. It was kind of that aha moment that led you
oh,
to what
yeah,
you're
the
doing.
aha moment, I would say, was I never anticipated I would be leaving psychiatric care and services as at the time I left, manager or leader. The aha moment was the Seattle Metro Chamber of Commerce contacting me while I was still in state government and saying, hey, we have people shanking each other in convenience stores and at gas stations over COVID safety measures. Can you help some of our business members with de-escalation training? And I was like, sure. And that was the aha moment. Like, so what we do is in demand, it's needed elsewhere. And there are people suffering all over the place. And once I got hip to that, I saw how desperately we needed support in our, let's say, supportive housing or unsupported housing initiatives, encampments, mobile crisis and co-response programs serving people with substance misuse or serious mental illness. And the need was like I was looking downfield one direction, and then that call made me kind of pick my head up and look around. And I said, holy, the need for this is everywhere.
Yeah.
And that was the aha.
Yeah. No, that's it's definitely a need everywhere. COVID was kind of a further catalyst, I think, to that need.
Awful.
Definitely. Yeah.
It
Yeah.
was an awful period in terms of our care of the elderly at that time. I was plugged into a number of providers who were working with the elderly, and they were not managing the iatrogenic or let's say bad impacts of COVID safety measures on the elderly with the isolation. And we said goodbye to my wife's mother. We said goodbye to her through a screen at an assisted living facility when we were still trying to figure out what the hell are the guidelines on how to manage the epidemiological concerns. And
Yeah.
there were just there were some awful outcomes associated to how we treated one another during that period, some of which made sense and what we've come to understand now, a lot of which did not. And I don't think you'll find a human being today that you bring up that time period and some kind of trauma doesn't come up for them. We had to say goodbye in my life to a number of people, and in some cases, I would say unnecessarily. Anyway, the providers in that environment needed as much de-escalation and support as people served because they were really not reconciling what were either being told to do or felt they had to do, and they knew it was going to have negative impacts. And that's what we've come to clearly understand now. So, yeah,
Yeah. And I think, well, and just in you talking, and I know that you have a lot of experience in this, and so it's a good segue. A lot of what happened during COVID was also just born out of fear, right? And so let's talk about fear management.
yeah.
Let's dive into that and talk about fear
Yeah,
management.
let's talk about what brought you and I together. It was our shared relationship with the great Tony Blauer. And,
Yeah.
both you and I had known about Tony's work before coming into contact with Tony himself. And I certainly remember reading about Tony's work in the journals 20 years ago and watching um you know, his messaging and education in periodicals and then later online. What became apparent to me from the psychiatric care and services context was that he had things that we did not have in the care and services training domain. The training in crisis de-escalation, crisis intervention in behavioral health has not changed much, I'd say, in the last 25, 30 years. It's generally an overview of the disorders, maybe a little bit about active listening, then a bunch of psychomotor skills, escort positions, bite releases, how to get out of hair pulls, and then someone checks a box that you've gone through de-escalation training. What Tony had was something far more meaningful. He had this idea that he always knew he had, but when we met and I described to him its utility in this space and the packaging that needed to change around it, he got it. It's very hard to de escalate anybody effectively if you're feeling afraid. So the fear has to be managed first. You can't lean into de escalation or successfully de escalate anybody if you're reeling from fear. The fear has to be managed. The way that he says it is those who manage their fear manage to fight. Well, in self defense, that makes a lot of sense. In de escalation, those who manage their fear manage to de escalate others. You can lean into de escalation if you're managing fear. And what we have found today is that we tapped on something very primitive within the training needs of our workforces across human services sectors. There are giant groups of people that are terrified of going to work. They do it begrudgingly, and consequently, it's very hard for them to engage any capacity to be therapeutic because everything is being done in the name of safety, which expresses itself as over control of circumstances and people to keep things safe, putting patients in the back of an ambulance in handcuffs when they're supposed to be in the semi-Fowler position, with their hands on top of them. We're doing things to people in the name of safety that are just straight abuse and straight ignorant in many cases. And fear drives a lot of those poor decisions.
Yeah, well, and I think not just fear management of the professional, but understanding fear of the person that you're also interacting with, right?
Oh,
And so yeah, that's something that I learned very early on. In fact, I was just having this conversation prior to our recording of this. The two main factors that I have learned that really drive patients is fear and pain. And before that very first touch point, whether it's triage or the very first time I'm saying hello to that person, I am assessing what are they afraid about during this whole experience, either right now or future fears, and what's their pain level right now, because those are the two things that I need to manage right off the bat in order to
unequivocally.
prevent. Yeah.
And in your sensitivity to that, look at what you're doing. If someone's limbic system is active, and if we analogized that to a fire, you're not showing up throwing gas on that, like spritzing it out of a 32-ounce spray bottle. Hey, you need to sit down before we do anything. Like with all kinds of, let's say, environmental controls that are insensitive to how the person is experiencing the world at the moment. Instead, you're appraising that and looking at the way to reduce risk by keeping things safe, by not stimulating their limbic system any further and making them activating their risk circuitry any further. It's already turned on. So you don't have to worry about that as a care provider, particularly in an emergency moment. Someone's nervous system is likely very, very limbic by the time you get there. And the idea that you're going to just run your agenda and have no impact on that is kind of naive. So good on you, Sarah, for assessing those things first. Sadly, in EMS training, we don't really talk an awful lot about the emotional arousal or the fear that the patient might be receiving. We describe a little bit about that in a different way, but it's certainly not the kind of education that's needed about being as non offensive and non stimulating to their limbic system as possible. And then we'll say these things like, well, if they're if dire need and we don't have time for OPQRST, it's sick, not sick, we got to move them. Yeah, I understand all of that. Like I've been there, done that. I got it. Got it. It doesn't mean that the person who's experiencing that, we now know, like the data is in, the jury is back. There are health implications and trauma associated to social isolation or controlling human beings. Period.
Yeah.
Period. So, how about we don't make it worse? How about we be professionals that are sensitive to these outcomes, sensitive to these states, and that we deliver our best care, which, by the way, is in the best service of ourselves. If we don't make constant mess in how we intervene or interact with people, as a result, we are incurring less workplace safety problems, less trauma, those kinds of things. We're empowering a capacity for resilience. And that's what we're after.
Yeah, I mean, I hate to say it, but a little bit selfishly, like, yes, it does serve me further on down the road to take the time to show that empathy, that compassion, and let that person's nervous system let them de-escalate themselves in a sense.
That's
And like you said,
exactly right.
don't
It's the primary motivation. In fact,
well, and
some of the toughest
autonomy. They just want autonomy.
and nobody enjoys the experience of having decisions made for them. It's almost antithetical to our wiring, neurologically, our cultural development. It's here in the West, that idea is very, very different. Now, listen, there are parts of the world where if I described some of the human services interventions that are going on, you'd say that they're medieval. And we do pretty good at a lot of things here in the West. But one of the areas we could absolutely do better at are in the services where, let's say, people have responsibility to attend to community safety by projecting authority and control. And our jails and prisons are perfect examples. We have some of the highest rates of suicidality or referrals to EAP in those workforces because of the frequency of challenging behavior that our workforce is presented with on a daily basis. And you and I both know William Young out in Omaha, The Nothing That Never Happened. He wrote that book about corrections, about how traumatic working in corrections is. We need intervention and support within those workforces that prioritizes their wellness first before they even talk about services to other people. Here's how we're going to preserve your wellness and your resilience. I think it's the biggest motivations.
Yeah.
Branson formed a whole business model around it. We take care of our employees so well that as a result, they take care of our customers great. He's not hammering them with customer service, or else. That's a whole different approach. And finally, today, we finally have traumatologists in fire departments now. We finally have people that are dedicated to the workforce. So if you want to come in and debrief following an adverse event or a really tough call, you're able to go in there and say, look, I had to watch a kid bleed out in front of me and we couldn't keep him alive. And now I got to go home to my 5-year-old. Like, I don't want to have to deal with this. And we're dealing with it right there now. Thank God we're finally getting that.
Yeah. No, and I unfortunately, I think in the hospitals, we're a little bit behind
Yeah.
nursing and providing that care. I also
Yeah.
think sometimes we're not quite to the culture where we will take advantage of that care either. It's
Yeah, I
there's
want to
still
thank
a
you
lot
for
of
saying that.
stigma.
Not only is there stigma, I would say there's some I don't even there are certain words I want to avoid, but I will say that I have found in my professional experience, I have generally found a good number of licensed healthcare professionals to no longer be curious about their profession or about people. That they're not particularly willing to appear as though they're in need. They don't want to look like they're in need of anything.
Mhm.
And there are personality reasons that people do this. I'm not just saying, the phenomena of not wanting to seem in need or vulnerable isn't at work. Of course it is. But when you're training the entire time in your education path has been, you're the arbiter of someone's life or death outcome, it's pretty hard to become willing to be humble and learn about some other ways that we can support ourselves, even in the face of the outcomes. I will share with you this. When the Psychiatric Emergency Response Team program was deployed in 2014 in a particularly violent place, forensic care setting, literally hundreds of hours of mechanical restraint and seclusion that were being used in the presentation of emergencies by people served living with schizophrenia, schizoaffective disorder, and then overlap to the justice system. We brought that number to within a week, negligible levels, like less than 20, and we kept it there for some time
Wow.
through the use of skilled de-escalation, emergency response, packaging. You call this number, the team shows up, all they do is talk, they take the problem off your hands and they manage it, and you're able to focus on the other 29 people you have to care for on your unit. When that began to happen, there were psychiatrists and nurses that were not happy with this. They were
Wow.
not happy with a team that was reaching and facilitating outcomes that were different than what they had been experiencing with the patient, or the seclusion and restraint they had been frequently ordering, or the, let's say, frequent use of PRN medication that was occurring, even in certain provider like physician nurse combinations. Like, we were collecting that data when these two people got together,
The
and
rates were
now
higher.
we're wondering the next day, while everyone is somnolent or, completely out of it, we would see a lot of activity. So I would say one of the fundamental reasons that they were not supportive of this is because somewhere they experienced the use of crisis negotiation team, psychiatric emergency response team, as an interference in their clinical judgment or clinical practice. They did not want to feel required by the medical director to have to call. And that was one of, I think, the leadership mistakes that occurred, where we could have spent more time engendering physician buy-in, but we had to stop the terrible outcomes that were occurring. They were awful. But all of that to say, uh, there are there are some people in the licensed professions that don't like any image that they're not in complete authority or control over their practice. And that, as a result, was an underestimated cultural problem in the long-term success of the crisis de-escalation model in psychiatric care. And it pervades today. The doctor is the doctor, the nurse is the nurse, the psychologist has an opinion, the master's level social worker has an opinion, but this is a physician decision. This is a registered nurse decision. And we've made a lot of progress, I think, in our interdisciplinary work over time, but don't think for a moment that that phenomena still isn't a problem, because it absolutely is.
Oh, yeah. No, I think that's part of a lot of what, is a pushback in nursing circles is dealing with those dynamics. I feel very fortunate in that I've been lucky to work all over this country and managed to work with phenomenal teams that are very collaborative and work really well together. So I feel very fortunate in that, but I am not naive to the fact that there are facilities and clinicians that are in situations where they maybe feel a little helpless and a little hopeless because things are happening that are causing moral injury, right? We don't want to treat people that way.
Right. Or that the moral injury, worse, the moral injury is the price of safety. In other words,
Mm.
that's the big myth that, let's say, can get me going when I hear rationale like that from, $1,000 a year paid psychiatrist sitting there explaining to me that, the moral injury is, it can't be at the sense or of safety. And so what I'm hearing you say is that you want to be able to exercise your right to make whatever decision you want in the name of safety. Meanwhile, the moral injury concerns are nested in a bunch of CMS and Joint Commission regulations on how we treat people and what we're supposed to do before we control them. That's why those things are there. It's not because, like, that's optional, and don't think for a minute that, I mean, I was in a command center operation for one of the largest CMS audits that they ever did in psychiatric care and services that resulted in tens of millions of dollars of funding loss to an entire system
Wow.
because of condition of participation failures. So, like, this idea that the doctor's judgment can eclipse CMS's decision to fund this or not, if you put people in seclusion and restraint long enough and those people show up, they're not interested in hearing things like this is an interference in our clinical judgment and you can't be here and we'll just take your system over. We'll take your care system over. We won't give you money anymore and you're not going to win that fight in court. So how about you work with our auditors, address the imminent jeopardies, and then make a corrective action plan to solve these things over the long term? So it's very sad when CMS itself has to pull stakes and say, we got to get out of here because we can't fund this anymore. And that's happened, like,
Yeah.
more than once.
Oh, yeah. Oh, I don't doubt that at all. How do you think you go about kind of helping to build that culture and
Sure.
change that mindset?
That's the great question. So I think Greg Smith did an exceptional job of exempling that. When leadership, I will say this first, I'm going to describe the behavior of one particular leader that's already been, what they did was anchored somewhere else. And then these leaders became friends, and now we're all friends. and we sit on the board of a nonprofit together known as Hope Reform. Greg Smith was the chief executive of the Pennsylvania hospital system at the time that he led them to excellence nationally, a center of excellence. They won the Innovations in Government Award in 2000 for eliminating seclusion and restraint. The CEO of the hospital and the medical director of the hospital went to every single emergency call. Think of that.
Wow.
And observed the decisions, observed the response, and provided necessary feedback and overarching vision of how they wanted this to change. And if a doctor would push back on Greg Smith, the medical director was right there with Greg to say, well, doc, for instance, if you want to continue to do it that way, maybe you can find a different hospital that you want to work at, because that's not the hospital we want to make here. And we'll help you with that transition. But, the idea that clinical judgment or clinical practice is independent of the cultural of the facility or the leadership is completely ridiculous. Try that at Mayo. You think you see people at Mayo Clinic engaging in less than excellence in terms of their practice? So it starts with leadership. And then it was the great Kevin Huckshorn, who's you know as well as I do. She's a doctoral level nurse. She was the lead author along with Janice LaBelle in the 6 core strategies to reduce seclusion and restraint and violence. She wrote them for NASHBED. They've been presented at the NRI. They've been around for a while. They're the only evidence-based practice that's been comprehensively published and studied to be called an EBT. And the 6 core strategies are leadership toward organizational change, the use of data to inform decisions, workplace or workforce development, seclusion and restraint reduction tools, the use of peers, and debriefing. You do those 6 things, you're going to get people all looking downfield the same way and reducing risk and increasing positive outcomes. So it takes a long time. There have been some places that we cleaned up years ago that are now back to, let's say, less than optimal cultures of care where there's not a lot of resilience and a workforce that's exhausted. And the talking points of we have a staffing problem, and it's not just bodies. I've been in settings, and I'm sure you have too. We've had more than enough staff, and we have the same challenges. So
Yes.
yes, we need more people. And yes, it's not just more people. There's more to do. It really all begins with leadership. It starts there unequivocally. If you want to get people to care about doing things better, the leader has to care about doing things better first.
Yeah. And I think, and when you were talking about Branson, you were talking about from Virgin, right?
Right.
Virgin. Yeah.
Guy sells
What's
record.
yeah,
He
yeah,
made rockets. Sells trips. It's
yeah.
got nothing to do with healthcare.
Yeah, but he's
You
got
know,
one of the best business models, and that's exactly what we take care of our people first, because that will trickle down to great customer patient care.
that's exactly right.
Seems like common sense.
Right.
And then, and you mentioned like staffing and still having problems, and I've seen that too. And I think, that is sometimes where that resilience and that fear management comes into play in
It's
taking care
everywhere.
of yourself, because you can have the staff, but again, as we've been saying, you can't control people. You can't control, the terribleness that some people do to each other, right? Comes into the emergency room, you can't control whether that kid just fell into a pool, right? And now they're laying in front of you. Like,
Our friend was right about all of it. That is what comes before nearly all of it, in my opinion. Also, if people managed their own fear, we'd have half the problems, half of what we got. And you and I are interested in people managing their own fear in the safety context. But this is occurring. Don't think this isn't occurring in the boardroom and in mergers and in workforce decisions or policy decisions or on the political front. The fear is everywhere. Fear drives the expression of legislation around some of these things. Fear, 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 fear. And then
yeah,
if you call it fear, you can be chastised for doing that because people don't like the association of fear being something that needs to be managed. They want to rely on the idea that there should be no fear. And I have to make these changes because I'm afraid. So if I rearrange external circumstances to make the fear go away, that's noble and worthy activity. No, it isn't. That's misleading everybody that you have no control over your emotional state and you must constantly change environmental factors in order for you to be okay. Well, we got a whole brand of philosophy known as Stoicism that is seeing a renaissance today, mind you. People reading Meditations by Marcus Aurelius and Seneca, and all of the psychological thinking that followed that, because fear does not attend to wellness in human beings. There are health implications of being afraid all the time, terrible health implications. People are not healthy and well and integrated when they're afraid of everything. They're not living their best lives. And we have a fear epidemic, frankly. It's everywhere.
Yeah,
So,
no,
I
I
mean,
would agree with
your
that.
point, Sarah, I think you're getting to the very heart of the matter, like Robin Hood arrow splitting an arrow. That's at the bottom, in my opinion. At the bottom is is all of that, you
Yeah.
know? And
Well, and I think fear is perceived as weakness too, right? If I'm feeling fear,
well,
then
that's the point.
I'm weak.
Yep, yep, and somewhere today in our society, that has become a merit badge. It's become a badge. I'm
Mm,
afraid. It's okay for me to be afraid. Well, no one here is saying that it isn't okay. We're not telling you that you're not feeling anything, but are you interested in wellness and safety and health? Using fear to manage those things and create them is not part of the mechanisms of what we know works. What great things have been created in fear and by fear,
right.
you know? There's preparation, when imagine if all Noah did was feel afraid about the rains coming. No, Noah got to work and built something to manage what was coming. And that's, if anything isn't inconsistent, that what's completely consistent with our friend's message. If you lean into de-escalation, you have to manage your fear. If you
Mhm.
need to lean into a violent encounter, you have to manage your fear. Victims of violence always are able to manage the negative outcome of being assaulted better if they brought their very best to the fight, to the ambush, or to the attack, rather than just
Mhm.
getting beaten to a pulp and afraid. Those people who can live with the trauma live better when they know, no, I laid it all out and I got my ass kicked, I got hurt, but I was proud that I fought back.
Fought back.
I'm able to live with myself. There we've sent out some very terrible messaging to our youth that being afraid is something that should be leveraged to influence the world around you.
Mm,
Our school safety, like our school resource officers and our positions hired by schools that do that work, are encountering that in youth to extraordinary degrees. Teachers that are constantly calling upon them to de escalate kids and then send them back into the classroom to only get re escalated by the teacher again because the teacher is afraid. And
mm.
so it's like a virus, it's everywhere, Sarah. And I'm just glad that I'm not infected with it, to be honest.
Well, I try to make friends with fear. Anytime it's one that awareness, right? And it's like, okay, what is this high arousal, right? I like to call them high arousal states. You and I think we're on the same page with that. Anger, sadness, fear, even happiness, it's all high arousal, right? And so it's understanding, okay, I'm in a high arousal state, but what's the motivation here? Is it anger? Is it fear?
Yeah, and what's interesting is it's high arousal, but if you were to put an fMRI on your brain and take a look at what was happening, you'd see electrochemical activity occurring in the brainstem and the amygdala and the mammalian parts of the brain. While it is higher arousal, it's not higher thinking, or what Dr. Porges would call wide diversity of thought and expression in the neocortex. High arousal, like Gary Nesner and Jack Cambria, the hostage negotiators, do it best. They call it the teeter totter model. It's like a seesaw.
Okay.
High arousal means reduced complex thinking. Lower arousal means higher complex thinking. Crisis negotiators need to be here, not here, where they're not here in high arousal, terrified, saying things to the hostage taker like, put the rifle down, put the rifle down, put the rifle down. That's not how negotiators go to work. You know what I mean?
Yeah.
Now, we may be setting up a tactical response to use force to solve the event, but the negotiator is in a far more regulated state. They're not in high emotional arousal. They're managing that. And they're saying things like, gee, we'd love to better understand why you took the entire office building over with a rifle. And, can we get some money and pizza in there? Does anybody need anything? Let's, as Gary Nesner would say, Let's reduce tension. Let's open a dialogue. Let's try to get to some shared understanding and let's not rush in there, you know? And
Yeah,
the thing that I think we would both agree with is that no one here is saying you're not allowed to feel fear. The
right.
impulses are normal. You're not going to avoid it. What we're
Yep,
proposing is the idea is just because you're feeling an impulse doesn't mean that it can't be managed. Those who manage their fear, Tony doesn't say those who no longer feel fear, manage to fight. No, it's those who manage their fear.
yep,
You know, you can't be brave if you're not feeling fear. You can't be courageous if you're not feeling fear. Stephen Pressfield wrote about that in the famous epic novel on Thermopylae, Gates of Fire. There were some Spartans that had that lion-like courage that was genetic in their code. Most Spartans were scared shitless that got trained out of them, you know? Most of them
yeah.
were not natural lions. They had to be trained to manage their fear. And I think there are a lot of people in many of the force disciplines that would say the same.
Yeah, I know for me, I think the biggest thing is curiosity. So, like, it's getting curious, right? It's when I feel myself kind of in that spiral, in that loop, the fear loop, right? We talk about the fear loop.
Yep.
It's let's get curious. And then what are my options, right? So, and widening, I think Andrew Huberman talks about this too. So, one of the phenomenon, right, that happens when you're in fight or flight is your vision will narrow in, right? That's why it's hard to recognize detail and things like that because you're focused in. And so, it's realizing what state you're in and then kind of looking up, looking like you said
Yes.
you're
Yes.
running down the football field and all of a sudden you looked and you saw that there were like five other play options available to you, right?
That's exactly right.
And so, it's widening that field of vision when you realize you're in that state and then getting curious about it and what are
That's
your
a hack. That's a
options?
beautiful hack. I couldn't agree more. And curiosity circuitry is not in the limbic system, it's in the neocortex. So, what you're describing is a hack into how to try to pump the brakes on getting completely aroused and in fear and in limbic activity. And instead, pump, 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 look around. What's my overwatch? What's my overview? Let me take all of this in. It's not just this thought in my mind's eye about how everything is going to suck in 5 seconds. There are other things happening. And that's how those things that Huberman does, I think he's been one of the greatest helps to the general population in the last 5 years with how he raises awareness over like neurohacks. Completely
Yes.
agree.
Yeah. Yeah. And actually, I first came across that with Brene Brown and The Power of Vulnerability, her
Yes.
book. And she talked about curiosity in the power of vulnerability, and kind of that same concept of, my brain is telling me this story, but what's the real story? And let's get curious about it and what's really going on here. So that was another one of my first experiences with kind of the power of curiosity, right? And how that influences us and can help us.
Yes, indeed.
So let's talk a little bit about you and I kind of mentioned touching base on kind of crisis response and security. And I really want to give, an overview and kind of an insight to that and how you respond maybe to like the med surge floor might be different, how you respond to psychiatric
Yeah.
floor with your security response.
Yeah. So I've had the good fortune to see a number of sectors that apply the use of uniform security in attending to some of the safety and security needs of the setting. This includes higher education, it includes facilities, agency facilities, prisons and jails, it includes hospitals, community-based hospitals and residential treatment facility and psychiatric hospitals, as well as corporate security, workplace violence prevention. Believe it or not, there are very, very big companies interested in this kind of talk that we're having right now when it comes to workplace violence prevention and threat assessment. I would say that in healthcare, particularly when there are licensed professionals calling upon a uniform security presence for help. One of the common problems is the idea that uniform security and calling upon them for support means that our obligations under the regulations no longer apply. And
What do you mean by
when
that?
well, let's say we have an obligation under conditions of participation for CMS and through JACO rules to exhaust all options before laying hands on a person. But a licensed professional feels fear, they call security, security shows up, and they do one thing. They
Okay.
resolve the problem. So the problem might be physical movement from where that patient is to a place of isolation. It might be some kind of show of support where a number of them remain on post to deter any further activity. It might be to do something more direct in terms of physicality with the person. Um, I think we have the people who work in security are underappreciated for this core idea. When they're called, they come. If you call them, they're going to come.
Mhm.
And when we don't, let's say, make them part of the interdisciplinary approach to how we respond to people, two things can happen. The first thing that can happen is that uniform security can wind up getting into some hot water if they're doing things in a security context that are not consistent with the spirit of the regulations. And don't think for a moment that doesn't happen. It happens. It happens in juvenile justice settings and care systems all the time, where people who are resistant to movement fight security. Consequently, they get dragged across the floor. This is captured on video. And then as a result, there's massive organizational embarrassment, human rights violations, disability rights, whatever state name shows up. And now we have all kinds of, let's say, counter arguments about why they had to do that. Then security gets chastised. Then they don't want to come, or they get gun shy, for lack of a different term, in wanting to be supportive because the last time they did what they were trained to do, they got chastised. And this is not fair to our security partners
Not at all.
at all. They, like any other first response group, are some of the most, fire service, I would say, they've got the market cornered on being celebrated for showing up. And I was a
Yes.
fire EMS for a while, so everybody loved, they're just so non-offensive. They eat donuts and they eat things and they do car washes and stuff like that.
Yeah, firemen
But
don't take
remember,
people to jail, right?
our yeah, our police partners have to make the scene safe for us before we can
Right.
go do work. And the same applies to security. They are underappreciated in their first response functions. And if you call security, they're going to do what they are supposed to do. And the people who are drawn to the security profession are generally people who have experiences where they have, let's say, already gone through the experiences of managing their fear so they can perform a complex task, which may be de-escalating someone up to and including acquiring physical control of someone to move them somewhere. Those professions also, very often, uniform security and healthcare, are among the most under-resourced in terms of professional training and development. In other words, we're not investing in the awareness raising and education needs of that workforce in particular. And because we have staffing crises and or other reasons why we can't commit people to training after onboarding. So I think we still
Yeah.
have a
Hey,
lot of
hey,
work to do.
Andy, can you
Yeah.
kind of repeat that for just a moment? Because I think there was some breaking
Yeah.
up. Okay.
Yeah, okay. Sure. I don't
Sorry, I
geez.
know I lost your train of thought.
No, I don't know. I didn't lose my train of thought. I don't know where to start over. I would say I think we have opportunities in our security profession, particularly in the healthcare setting, to support those workforce members with meaningful training initiatives that emphasize the use of influence and crisis de escalation skills to avoid physicality. And while you'll meet security professionals all the time that say, we do everything we can to avoid it, if you were to audit their training and policy around that and then look at the events, you're probably going to see that that's not the case as much as the claim is made that that's the case. Sarah, looks
Yeah.
like you froze again.
Am I freezing too?
Yeah, I see myself going fine. Am I freezing?
Yeah, on my end, you were freezing and I was
On my
okay.
end, you were freezing.
Oh, well, maybe
Yeah.
maybe we're just frozen in time and meant to be in this episode
Yeah.
forever.
Awesome. So, I don't know,
Well, no, I think to your point, I mean, saying that they, that if you were to audit, I know a lot of, being in the healthcare and involved with healthcare security now. a lot of like former law enforcement, they retire and then they come over to healthcare security and they will say, I am more hands on in healthcare security than I ever was when I was,
They all say
working
it
a
because it's
yeah,
true. Yeah.
yeah.
I knew police officers that would say, I would never work at a psychiatric hospital. You're having to deal with getting hit almost every day, like every hour of every day. And where I was, I mean, that went on every 15 minutes. Some kind of physical intervention where we're running to an emergency where two people are about to go to work and we're only using our words to de-escalate that. I mean, talk about a frequency of practice development. It was working in a place like that. It was where the fights are occurring literally every 15 minutes. And what we're seeing today is our method to this now is being leveraged by. I just spent a good deal of time with one of our largest juvenile justice systems in the country in Chicago.
Okay.
And there are people in the response team context there now using our crisis de escalation approach to managing kids that are presenting extraordinary levels of opposition and defiant behavior, and having to deal with a system where there's an extraordinary amount of revolving door phenomena. Where, in fact, one of the shift lieutenants told it to me this way, and his name was Branch, just a wonderful guy, been with the system for 25 years. Andy, some of these kids that we work with get the most structured parenting they ever had in their life on these units here. And when we lose the ability to support them and they go through the monitoring and the probationary period and they get back out to community and they return to a house with family of origin issues, or they return to gang life and they try to re-engender some sense of meaning and belonging within the gang, which includes criminal activity, they'll wind up getting jacked back up and coming back in here. And we see the same kids that we're reparenting over and over and over as they come through these doors. And the pressure on our juvenile justice workforces is higher than ever before. And there are many juvenile justice environments that are resorting to the use of administrative and episodic confinement, room isolation, in the management of emergencies. And the problem with that as an interventional approach is that it does not bring about a reduction in emergency. It increases the likelihood of emergency, it doesn't decrease it. So the medicine itself for the problem is making the problem worse. And finally, there are some people who are trying to reverse this order. So, to our security professionals, I would say, remember where hostage negotiation was born. In the 1970s, in a sporting goods store in Brooklyn, the first hostage negotiation event occurred on scene where Dr. Harvey Schlossberg showed up to say, hey, before we go in there, guns blazing, to take out the hostage takers and accept the collateral damage, how about we open up a dialogue? How about we contain the scene? How about we talk with the hostage taker and try to prioritize life? And it's going to take longer, but how about we do that? That was the beginning of the hostage negotiation, let's say, movement, which led to the FBI's work, Gary Nesner's work, Jack Cambria's work, Frank Boltz's work. In other words, that this whole idea of slowing things down, let's reduce risk, let's take the necessary time to manage our own impulses that are screaming at us to control this. Let's manage those and try to render real control by giving someone a sense of empowerment over their own self regulation. A totally different deal. And when the stakes are life or death, no one seems to object to that. It's when the stakes are less than that that people get impatient. An oppositional defiant kid, a patient that does not want to comport with a medical procedure. These are events that can be irritating to the nervous system. And it's when decisions to control are premature that we get into problems. And there's a difference between saying to your kid, put the controller down and go do your homework. You can do that, or you can say, hey, looks like you're playing Xbox. I like Xbox too. The rules in our house are that homework has to be done before leisure activities are enjoyed. How about you put the controller down, go knock out your homework? That way you can come back here. You can play some video games before bed. Now, obviously, that takes longer to do. I just sequentially walked through validation, deferring to a shared value, suggesting an alternative, and describing a desirable outcome or prompt. Remember it simply, we call it VDSP: validate, defer, suggest, prompt. Validate. Looks like you're playing Xbox. D. The rules in our home are that this needs to get worked out with homework before you can enjoy leisure activity. Suggest. How about you go knock your homework out? Prompt. That way you can come back here and play your video game later, or you can keep your video game and play it tomorrow. Yes, that takes longer to do. Yes, you have to practice doing it. But what it doesn't do is result in bad medicine. You enable someone to make a decision that is in their own best interest, which is, quite frankly, empowering someone that way. That's real power. That's
Mhm.
real influence. That's really doing something meaningful to reduce the likelihood of future emergencies. So I think we have extraordinary opportunities in uniform security and healthcare to collaborate more rather than the way that we're doing it in many settings where providers feel afraid. They call the people that are willing to manage their fear to do a thing. And then as a result, we wind up turfing ownership of the event to them. Um, and what they do very often, if they're not collaborating, could be not in the best alignment or value with the care system, but it's obviously needed. They need some kind of structure and control needs to be brought to the scene. Let's support them in as many ways that if you're going to do that, let's empower them to do it in the most non-offensive way possible, which only helps their own department, the employer, the workforce, and the people served. Let's reduce risk.
Yeah, well, and in you talking, I'm kinda talking about that, the one thing that kinda pops to mind because you were talking about, the provider, nurse maybe, fear, I'm gonna call security, right? And then
Happens all
but
the time.
then right, but then later on, like CMS, Joint Commission, they're looking to see, okay, well, did you follow, like, all of these things before you went straight to, restraining somebody or something like that? And
That's
so
right.
right. And so this is and for our nursing listeners that are listening, this is where your charting becomes really really important. And being able to chart the event and show the escalation, show what your interventions are. This is why I'm a really big proponent. And you and I have talked about like using the bro set. And there's the bro
Right.
set, there's the DASA, there's the what is it, the ABR, yeah, I think then
Yeah.
there's the violence assessment tool. There's like numerous tools out there that aren't being implemented in nursing practice. And this is why I'm a huge proponent of it because this is where then you can use your charting and you can show what you are doing and the progression of these escalations. You put your policies in place, right? This is our security response. This is our behavioral health team response. These are our nursing interventions, right? There's nursing interventions that can be done.
Of
Nurse
course.
makes right referral to social work. And so but when we don't put in, you're talking about structure, right? And what we and it's the serenity prayer, right? Lord grant me the to
You accept the things I
ex-
cannot change, the courage to change the things I can, and the wisdom to know the difference.
yes, yeah, exactly. And so, we can't control other people. We do not have that power, right? But we do have the power to set up the systems, right? Structure our systems. These are structured professional judgment tools, put them in place so that we can show that we are doing all of these things when we're interacting with these people and help guide that.
Sarah, I spent a good deal of time auditing documentation, not only of our own psychiatric emergency response team members, but in, let's say, critical incident review that made it to a committee that I was on. And in nearly every instance where we saw opportunities for improvement, what we would see are inferences in the charting. Patient was harassing, patient was threatening, patient was intimidating. The regulatory authorities are onto this. They don't accept that anymore. What they're interested in is specific behavioral observation. What was threatening? What was harassing? You have to describe the difference between you felt afraid because they were harassing and instead write, no, the patient held up their right hand over their head with a closed fist and said, I'm gonna effing brain you, you bitch. That's what you chart. And when you do that, it helps an auditor understand, oh, okay, well, the response here was completely reasonable because this speaks to imminence. Where did this occur? In the day room at near contact distance. There wasn't level 4 polycarbonate between the people where there's no way the hit would have occurred. You know what I mean? So, like, that specific behavioral observation charting is what everybody seems to be on to now. Thank
Mhm.
God it took years to get here, but avoiding inferences is fundamentally important within the documentation.
And I think you brought up a good point that I didn't really, like, think about is also charting, like, where, right? So, in patient's room or in
Oh,
hallway and, like, charting,
absolutely.
like, where. Not just, like, what are they saying, what's their body language, but then also charting, like, where in the facility it was happening, right? Are you in the waiting room? Are you in somewhere where there's other patients that are close by, that sort of thing, and
Yep.
being able to specify
That's
that.
all situation and background, right? We were talking in the green room about
Yeah.
were you S-bar or were you soap?
Yep.
Um,
That's far.
so, what's the situation? I'm standing at the meal service area where the spider tables are behind a gray cart serving meals to our people served. It's lunchtime and each person served approaches the lunch cart to accept one meal. When a patient came over or person served came over to ask for a second meal, I had to perform a denial of request. I let them know that we only give out one meal per customer, one meal per patient, and then the following ensued. They said, I'm going to effing whoop your ass if I don't get another meal. In other words, you're quoting things. You're creating an image rather than using words like they became harassing and leaving that to the imagination of the reader. What the hell happened? You
Right.
know, in fact, I know that reading reports like this are boring because there's you're just reading specific behavioral observation, but it's so fundamentally important to confer to a reader or an auditor what the hell happened, and it'll only cover you. It'll only help you if you do that,
Yeah,
you know?
absolutely,
So,
absolutely, and
yeah,
it just helps, it helps to guide interventions too, right? To really just be able to
completely,
describe
Sarah.
those behaviors, so
Yep.
well, Andy, it has been a pleasure to have you on today.
I feel the same.
We're going to have to come back for sure.
Yeah, well, hopefully Tony and I can come back and talk a little bit about spear care, and
Yes,
I think that would be so delightful. But Sarah, let me just say that I love the work that you're doing with the Security Nurse podcast. I love the awareness you're trying to raise and your target audience of people who are in nursing and the healthcare profession. It's so desperately needed that I feel very privileged to have had an opportunity to come here and just kind of act in the animated way that I can act. But it's all in the spirit of raising consciousness and trying to be supportive to the workforce. If I can, Sarah, is it okay if I mention my website
a
here if people want to learn
yes,
more?
absolutely, I was gonna ask you if you didn't, so
Yeah,
yes.
so at Jumpstart Mastery, we have a bunch of courseware that is a product of all of these experiences that I've discussed here with Sarah today. Just come visit us at either jumpstartmastery.org, which is our primary website, or jumpstartmastery.com, which is our online community that's hosted on Mighty Networks. There's an extraordinary amount of online courseware in verbal de escalation, advanced crisis de escalation, hostage negotiation, an online community where we have events every week. And I'd also say that we're very busy delivering in person training throughout the country across sectors, tribal communities, healthcare settings, juvenile justice, adult corrections, workplace violence prevention in corporate environments, mobile crisis, co response, fire EMS. There's an extraordinary training need for these skills. And if you're interested in them, come see us at jumpstartmastery.org and jumpstartmastery.com. We'd love to help.
Fabulous, and then, I can also put your LinkedIn profile as
Yeah,
well
please
if you're
do.
open
Yeah.
to that
And
so
I'm
people can
always
connect with
doing
you.
stuff on LinkedIn for sure.
Yeah.
Yep.
Yep, fabulous. Well,
So,
thank you.
thank you.
You're welcome. Thank you for being I know.
We get animated together. You're
We
an
do.
old forensic psychologist friend of mine used to say, "Andy, you and I fan each other," you know?
Yes.
That's what I feel like we're doing. Whenever we talk, this is what happens. So,
We're
Sarah,
both
all the
ve
very best to you. Lots of warmth and affection to you, and thanks for what you do.
well, thank you, Andy, I appreciate it, and
You
same to
bet.
you.